talked about here before. And people were hearing from other people that attended that they had to come.
Oh.
So that was a good,
Okay.
that was really good.
I saw the school bus out there when I pulled in, and I was like, oh my God. This could be interesting.
That's my bus. I should have warned you.
Literally terrified. Hi, darling.
So yeah, we were just kind of going around the room. So we were back. We're at Kelly. This is my sister Kelly.
Oh, here's Sister Kelly. Oh, I've heard about you.
Because Cassie came last time, so now Kelly heard about it. She's here. So.
It took me a minute to talk you into it, huh? Okay, welcome.
Postmenopausal. Frustrated that no one in the area really can give me any answers. That when I first started asking about it, they just had no idea, no clue about advice or anything like that. So,
And you've had a hysterectomy. So, yeah.
Well, I'm Audrey, and I sailed through menopause. I don't remember having it.
Oh, good.
But now it's like, or getting through it, I should say. But now it's like all these little things are going wrong. It's like this, and this, I mean, I gotta watch that, and I gotta do that. And wait, now this, you want me to go where? So I'm just frustrated with how come all of a sudden all these little things that aren't so little are going wrong, and I want to learn more, just more about the body, and if there are any other avenues I could take.
Okay.
I'm Sherry. I'm already a patient of Dr. Coggins. I think I've been seeing you about a year and a half or so. I feel kind of blessed in that I was at my annual checkup for just my pap smear and stuff, and I said, I think I'd like to talk to somebody about hormone replacement, and they said, oh, we have somebody in the office that's a specialist. We'll just get you an appointment. And I feel like myself again, but I'm just curious what else you have to say outside of our regular appointments.
Aw, nice of you to come.
And Sherry is the reason Judine is here, because Sherry, I started asking all my clients, and she told me about her, and I was like, that's it. I gotta talk to her. She's the one.
Oh, okay.
So that was
Snippet.
that's how the ball got rolling. You know, Sherry brought it up, and I was like, this is great. I've got to see her. And then yeah, great.
Hi, I'm Candace. I'm here because my friend Dawn suggested, so I'm here. But postmenopausal too, just here to learn and hear what you have to say.
Yep, and I'm Dawn. I didn't drag her, she did come with her free will. Mostly because it's a long drive. But postmenopausal, and I thought, oh, I'm done with hot flashes. I'm done with all that. It's like, oh, no, I'm not. And hot flashes and night sweats are starting to come again, so I'm thinking I'm missing something of, you know, what am I eating or what am I drinking, that they're coming back stronger now than they were before, so.
Okay, I missed the other people.
Yeah, please.
I'm Rebecca. I was sad that I missed you last time. I heard so many good things, and I'm just starting my journey, and I've had some bad experiences with doctors, and I refuse to go now. So I think this will be helpful for me to get more information and just be empowered when I do go.
Okay, good.
I'm Marissa. And said I'm perimenopausal, so I'm right in the thick of things right now, and haven't been listened to by doctors. I did find someone online, and I just started HRT, but like I feel like an experiment.
Oh, okay. I think we have more information than that.
Way.
Lynn, and I'm postmenopausal, and the journey's been something because especially the last 3 years have been really something. So, and a lot of it they attribute to my thyroid, and I was just recently diagnosed by Dr. Levy with Hashimoto's. So, they're saying that that's the issues, but I don't know. Yeah. So, yes.
Hi, I'm Lori. Let's see. Been through menopause, but still having hot flashes. I've had histamine intolerance, hypothyroidism, and just looking to see what other pieces of the puzzle I can add to
Hi.
Back again?
I'm
Back
Jerry.
for more?
I'm here every time Dr. Coggins is here because I can't get enough. I had a complete hysterectomy many years ago, and my journey has been an interesting one. And I needed some help. Sarah and I were going through similar situations, and I learned, and I was able to get an appointment, and I am just really excited to learn. I feel like there's so much information out there that women don't have and they don't have access to, and so I feel this really strong, not just for myself to learn, but I have 3 daughters, I have hundreds of women clients, and I just wanna understand as much as I can so that I can help people get to the resources to feel better, because there's so much stuff that women just live with because they feel like they have to, and I think that that's almost rarely the case. So I'm very grateful that Sarah has brought you here, and I'm very grateful that you are here. And I'm able to.
I'm very grateful too, yeah. And the amount of people that we've been able to reach, and then they tell people, I mean, word is spreading, and you know, that is so empowering because they're getting options that they've never heard of, or they've been shut down. And just like in my own, we were just talking that I see Dr. Levy, and he's the one that originally put me on HRT, but wanted me to follow up and find someone, which took several times, which I finally found a place that was like, yes, we'll prescribe, we're on board, but they didn't know how to adjust it. And when I had breakthrough bleeding, they were like, no, you can't raise your progesterone, that 100, that's it. And I'm like, are you sure? Because I kind of feel that this would be, no, that's it. And then I sent Rebecca there. I'm like, well, before I knew that, but they're prescribing, like they're on board. So she went, they jacked her up like as high as, fast, and poor thing was a mess because they didn't do it slowly. So, and then I'm like, oh, because here, I thought, they know what they're doing, they're prescribing, but they didn't. And so it took me many tries, and then, as I said, I found Sherry told me, and then it's great because when you go to Judine, she does blood work, but she looks at all your symptoms, you have a conversation, she learns a lot about everything, your whole history, and she takes time, and that's like Dr. Levy too, like they sit and they listen and they really see the whole picture. They're not just like a number and oh yeah, just go, she knows her stuff, and so then she follows up with blood work, and she goes, slowly and really looks, and so you're never feeling these big swings. You're going at a good rate, and I feel very optimal right now, I have to say. So, enough.
And I missed our lady.
Oh, sorry.
I'm Patty, postmenopausal, and yeah, I want to feel optimal.
Okay.
I'd love to
Great,
describe
right?
what you-
All right, ladies, let's go for optimal. I like that.
That's what I thought.
I like that idea. I'll start with the appointments. They take an hour minimum, right? So I'm seeing postmenopausal women. They're 50, 60, 70, 80, 90 years old, and that's a long history to go through. Just starting with the history, right? So your medical history, what were your periods like? How many kids do you have? And all the surgeries, whatever you've had, and then hearing first and foremost, what's wrong? What's wrong? How do you feel? What is wrong? And what has been tried so far? So that takes a long time. I scheduled the new appointments for an hour, but they probably take longer, especially if you don't have a gynecologist too. So I do take patients as new patients for GYN care or just hormone care. If you love your doctor, nobody has to switch their GYN to me just to see me. I will just do hormone consult. So nobody, you don't have to. You can if you want to. So that too. Okay, so I guess let me just, do you mind, I'm just gonna stand.
Yeah,
So,
of course.
I'll tell you a little bit about how I got started and everything, my career. So when I graduated from residency in the late 90s, every woman went on hormone replacement. Every woman went on hormone replacement. They went on Prempro. And in 2002, the WHI study came out, and that study was stopped early with a fear that hormone replacement caused breast cancer, heart attack, stroke, blood clots. And that terrified doctors, women, and then for the next 20 years, we have had you can't go on hormones. All hormones are bad, and they've all been put into this category. There's some really great studies out there that take apart the WHI studies. So, the WHI study, basically, it was a great study. They had over 10,000 women, and however, more than half of them, or 70% of them, were over age 63. 50% of them were obese, smoked, or already had high blood pressure or other heart disease. So these were women who already had heart problems, had medical problems, and then they were given hormone replacement. And so when someone looked at that, then they were like, oh, okay, yeah, so you should only take hormone replacement right after menopause or immediately after menopause, because if you take it later, it's gonna kill you. It's gonna give you breast cancer, and it's gonna kill you. So that isn't exactly what it showed either. So, since that time, there literally, and before that time, there are decades of study showing that hormone replacement is beneficial. So the WHI study looked at one drug. So it was Prem-Pro. Premarin, which is conjugated equine estrogen, which comes from pregnant horse mare urine. There's at least 10 estrogens in that, and only 4 of which might be human. It's assumed that that's going to act the same in our bodies as normal as our bioidentical or our estradiol works, but it doesn't. And then the progesterone is called Provera. So I don't know, some of you probably even been on this at different times, and it's a progestin. So they take the progesterone molecule, they take it into the lab, and they tweak it a little bit, and now we got a new drug. We can make a little money on that new drug, and it is also assumed that this is going to act the same in our body. So actually, it doesn't act the same, and it's actually the synthetic progestins that are the problem as far as the increased risk of breast cancer. They cause an increased mitotic rate. So I will prescribe these. The Provera is dirt cheap, right? So if somebody has an episode of irregular bleeding, you need to stop it. Yeah, a short course of that, no one's gonna get breast cancer from that. But I don't put women on long term, especially perimenopausal. I'm just not doing that anymore. The risk of breast cancer, though slight, is increased. So it increases mitotic rate in the breast. So progesterone, the bioidentical molecule, decreases mitotic rate. So when we have mitosis, this is cell division, high rate of cell division, this is when breaks in the DNA happen and starts to go down an altered path, and that's where cancer happens. So if you are having an increased mitotic rate, you are increasing your rate of that possibility. We all of our cells, are in a constant death and growth cycle, but if you're increasing the rate of mitosis or turnover, you run that risk. That's how that pathway happens. So bioidentical. So this is a terminology that is interesting. So it is bioidentical means it's identical to what your body makes, identical to human. So if they took a bioidentical progesterone and they pulled blood from you and looked at your progesterone, no chemist in the world would be able to tell the difference of those. But it's not coming from a human. It is, the one I use is plant-based, but there's no plant that makes human hormones, right? That would be great, but there just isn't. So that molecule is taken into the lab, the plant-based molecule, and turned into bioidentical chemically. There's been some, like my governing body's ACOG, American College of OBGYN, and NAMS is the National, I forget exact, Menopause Societies, I forget what the A is.
Association.
Yeah, there you go. They have a party line based on that WHI study, lowest dose possible, as early as possible, and for the shortest amount of time. You got to get these women off this stuff. Okay, so they've touted that party line for 2 decades, and then bioidentical doesn't mean anything to them. It's just doesn't. It's not meaningful. So kind of an uphill battle to fight my governing body. I think NAMS has recently come out with something that says it's okay to take hormones. So the bioidentical, the problem is if you're getting something compounded, it's not controlled by the FDA. However, where I recommend we get the compounding products from, they are pharmaceutical grade, so it is FDA approved, and then they're compounded into your product. Most of the time, estrogen, estradiol can be bought commercially. There's no difference from the commercial and the compounded. I don't recommend, we don't need that. We have excellent commercial estradiol and progesterone too. Very rarely is the progesterone, like we can't get somebody's blood level up and then I have to think, well, we either need the brand name or we have to have it compounded because something's not quite getting absorbed, right? So, but that means that I have to look, right? We can't just say, here's your dose, you're human, this is what you're getting. Every person is different, every woman responds different. I've had women on extremely low doses of all the medications that get their first blood levels back, and I'm like, wow, you are nearly optimal. You are my best patient ever. You are doing awesome. Not that if your labs don't go perfect that you're not a great patient, but it's just like amazing. And then other people, I'm just up in the dose, up in the dose, up in the dose. So it's not just the blood level either. I'm looking, how do you feel? Let's make a list of your feelings, of the things that are bothering you, and then we got something to look back on, right? So I write it all down, I put it in the note, my note, and when we go back, I can say, well, you know, how's the urine doing? Are you still having that frequency? Oh, I forgot I had that. Oh, yeah, no, that's fine. No, I'm sleeping through the night. No, it's all great. So I think I want to talk a little bit about our hormones in our body and where we start in youth and what our goals are. Thank you for this.
Yes.
I have to draw my picture. If I don't draw my picture, I don't know how to teach then. So, all right, let's.
Can we hold it?
No, I don't know. Do you not have a stand thing?
I don't.
Okay, you know what? You need one of those.
I have one. Hey,
We don't need an
someplace.
easel, yeah. Okay, so if we are thinking about the menstrual cycle, so many of us are postmenopausal, perimenopausal, but we have to start here because this is where the hormones are. So it's basic probably for some of you, but it'll be a good review. So day 1 is the first day of bleeding, 14 is ovulation, and day 28 is the same as day 1. First part of the cycle, the lining layer is thick, we bleed, as expected it gets thinner, and then it starts to get thicker again. This getting thicker again is related to estradiol. Let me see if I can write it this way. Every month we make a cyst, and then we ovulate. Ovaries make cysts for a living, that's their job. We ovulate, the cyst ruptures, and the cyst that's left behind produces progesterone. Progesterone stabilizes your lining layer, it no longer gets thick, it just gets more dense, and then we bleed again. So in a situation, estradiol, where you're not ovulating, perimenopause, menopause, the body can, if the ovaries are still working, you could be making excess estrogen, and the lining layer can get thicker and thicker. When you do bleed, you bleed irregular and you bleed heavy. So this is a lot of women in the perimenopause start having these heavy cycles. It's because they are ovulating maybe every other or every third month, and you're still making estradiol. So you're making this thick lining layer, and then if you didn't ovulate, you don't have progesterone. So progesterone is your turn on shut off mechanism for the period. So if you don't have this, it doesn't know when to stop either. So this is where this perimenopausal bleeding comes in. Normal menopause looks like lighter and lighter periods further and further apart. But, you know, we live in Buffalo, we are not like normal body fat women. Many of us, not all of us, but many of us. So we are overweight, obese, extremely obese, and we convert any hormone in our body to estradiol in our fat cells. So even in the best of times, we have extra estrogen. Our Buffalo ladies, we've all got this. So, so let's talk a little bit. I'm sure some of you have heard about like PCOS, right? So what is going on here with PCOS? So in PCOS, we're gonna look at the ovary here. So this, you're gonna see I'm an artist right off. Okay, I'm an artist. So this is the ovary, right? So we have this cyst, and it starts out making estradiol, E2, and then we ovulate, and then we're making progesterone, P4. In a situation where we're not ovulating, the body is like, what's going on? We need to ovulate. We're trying to procreate. We need to get pregnant. Let's go. So it says we need more estrogen then. Well, the precursors to estrogen are actually androgens. Well, the precursors to androgens are actually cholesterol. So as soon as you start going on those low cholesterol lowering drugs, which by the way, ladies, statins do not have any primary data in women. It's not shown to be a benefit to prevent that first heart attack. Even if you have high cholesterol, not a benefit. In fact, increased risk of diabetes. So it's, in men it's not even that great, like a 4% decreased risk of the first heart attack, 4%. Nothing, it's nothing. So it's a big money maker though. Statins, huge money maker. Okay, so you need cholesterol to make hormones. All hormones are cholesterol based. Okay, so you make this androgen. So we need to ovulate, so we need more estrogen, so we make more androgen. And then we're still not ovulating, so now we need more estrogen, we make more androgen. So now you start with the hair growth, and they keep making these cysts every month, and then it's polycystic ovaries, and they're fully bearded with a really high voice. Because we got a lot of estrogen, we got a lot of androgen. So we got both. So these poor girls who start out at 13, 14, missing, only having 1 or 2 periods a year, end up with very high androgen level around the ovary. Now they can't ovulate, they can't get pregnant. So I am trying to teach the residents, these young girls need to go on a birth control pill. They need to shut that whole thing down until they're ready to conceive. So if you shut this whole cycle down with like a birth control pill, we're talking younger women, this high androgen around the ovary shuts off for a while, and when they come off the pill, they might pop out a couple eggs, and that's their best shot at getting spontaneous pregnancy. So I know this isn't our talk about infertility, but I'm sure a lot of you have had different things, different fertility problems, have heard different things, friends with fertility. This is the PCOS. So what happens at menopause is kind of a similar thing. The brain keeps saying, find an egg, and eventually this petering out ovary finds an egg, and now you shoot out estrogen. Just literally shoot out estrogen. At that time, estrogen's the bitchy hormone. This is the one that everybody's like, oh, she is crazy. She's batshit crazy. She is. What? Did you see? I gotta walk away from mom. She's just completely crazy. So, and what's happening is we're having these spikes of estradiol, right? You're not ovulating, so progesterone's your stabilizing hormone. You're not ovulating. You don't have that balancing. So you are actually crazy. It's not a feeling. You actually are kind of crazy. So this is what happens in the perimenopause. So let's see, where do I want to go from here? I want to talk a little bit about other hormones. So progesterone is our balancing hormone. So if we replace the progesterone in perimenopause, not estrogen, you're already having spikes of estrogen. If I give you estrogen and you're in the perimenopause, you're going to be fine one day, but the next day, the brain is going to be stimulated. You're going to finally find an egg. You are going to go completely crazy. You're going to be crying. It's going to be like, what's going on? I was already over that divorce. Why am I crying today? So, right? So you cannot give estrogen in the perimenopause until you have to be no menses for a full year and have a blood level from the brain that says high FSH, that says you are actually in menopause before I'll start estradiol. Problem is sometimes people have had a hysterectomy and they're 52, 54 years old, and you don't know, when should I start this? And I've gotten burned a couple times, like, damn it, I gotta have the high, I really, when can we start the estrogen? Okay, let's give you a little estrogen, feel a lot better, but I feel like I need more, and then something tips, and they come in crying, and I've lost a couple patients with that. They decided that I've totally screwed them up. It's hard to know exactly if you don't have a uterus. How do I know how much estrogen is a good amount? It's hard to know. So it's how you feel, and it's the blood levels. So we have, you are not a textbook, and I am trying to read you best I can, but trying to sort that out. Mm-hmm. So let's see. The next hormone I want to talk about is testosterone. So testosterone is sex drive. This is our sex drive. And at about age 40, well, actually before age 40, in our youth, in our hot to trot, late teens, 20s, our testosterone level is actually higher than our estradiol. So it It is part of our drive, our sex drive, but it's our overall drive. This is our drive. I'm gonna get up, I'm gonna get it done. I'm headed to the gym today. This is gonna happen. I'm getting it done. At about age 40 is when the testosterone level really starts to go down. And this is around the time when a lot of marriages start to like fall apart, because you're like, okay, my mother-in-law's coming for dinner tomorrow. I gotta get the roast out of the freezer. The kids, we got 2 soccer games and that hockey game, and he wants to have sex. And you're like, really? No. I can't get there. And he's like, what's going on? And I'm on track with, and this whole pattern of things happens, and really it's the testosterone level is going down. So yes, all those busyness things are happening, but the desire to make time for that diminishes as that testosterone goes down. If I check your testosterone level, it's going to be normal for age. It's going to be in the toilet, however, right? It's going to be nothing. So that first testosterone test I had was literally like 1 or something. I mean, it was terrible. So I lived through that. I lived that. And so we start replacing testosterone. So testosterone, the way I do it is with a cream. There's other choices. It is a controlled substance. Which means that it's the steroids. It's not methyl testosterone that the roid rage gym rats are using, but because of that, it is a controlled substance. So I can only give you a month at a time. We have to renew it every single solitary month. I do kind of eke that out. I kind of hedge my bets by saying, give her a little more because we're going to have dosage changes, and I can sometimes get away with a 3-month supply, but it has to constantly be reordered as if I'm giving you a narcotic. The testosterone I usually prescribe as a cream that's placed on the vulva at night. So how do I replace the testosterone? So if we're looking at blood levels, for a man to say that he has hypoandrogenism, he needs a blood level of less than 300 on 2 8 a.m. blood draws. And at that point, they could replace his testosterone and insurance would pay for it, the starting dose being 200 milligrams. For women, our goal is to get up to 300 and our starting dose is 5 milligrams. So I'm not giving anybody a sex change. Nobody's transitioning here. This is not what I'm looking to do. These are very, very low doses to get our blood levels up. Can there be androgenic side effects? Some people I had one patient who says, I love my dewy skin. So oilier skin, oilier hair, thicker hair, a lot of benefits from the testosterone besides just the sex drive. And it takes a minute for that to come back, but just having the sensation of desire is gonna do wonders, but it's really, I'm not really as interested in that, although I love to see you happy. It's not that. I'm interested in your health. I'm interested, can I get up and do the things I need to do? Can I go out and, am I actually gonna build some muscle here at the gym? Is it actually gonna work? Do I have the, am I moving forward? It's not just barely standing still, am I actually moving forward? So benefits of hormone replacement. I think a lot of you understand that the difficulties of menopause, right? So osteoporosis is a big one. So actually the testosterone is better than the estradiol. So it's not just the bones though. This is tendons, this is the infrastructure around the bones that is strengthened by the testosterone. So the estrogen, all those drugs that were created for osteoporosis, the injectable, the once a year stuff, the stuff that you had to stay upright for, all of those drugs were a substitute for estrogen. When we said we couldn't take estrogen, they had to come up with new drugs. These are big money makers. They don't actually do as well preventing fracture, and there is the spontaneous femur fracture that can happen. And my dear friend had a just terrible experience with a patient who had that. So other ways to give testosterone: pellet therapy, injectable. I don't do the injectables. I wouldn't even know where to get that. I guess I have a lot to learn still. I am a work in progress, ladies. I am. I have done 3 parts of a course to be certified in bioidentical hormone replacement. Part 4 is in June. they're only giving it once this year, so I've got to get to that. It's in Utah. I can do it. I'm not sure what I'm going to do because it's the resident graduation. And, you know, when I said to one of the resident physicians, because I train the residents, I might not come to graduation, she was like, "What? You're not coming to graduation?" I was like, "Mom's not coming to graduation?" Like, so I might do it remotely, but I am going to get that course and I am going to get my certification and, you know, just continue to try and learn and see what I can do to help. I work at the hospital. I'll tell you a little about that. I work, when I first started out, I was in private practice. And like I said, everybody was on hormone replacement. And then I had my kids and I ended up staying home for a couple of years. And then I started working at the hospital, just moonlighting, picking up an overnight shift, supervising labor and delivery and running, you know, teaching the residents, which eventually morphed into a half-time job that between the residents and my husband who wanted a stay-at-home wife who made full-time salary, which that was hard for me, I ended up working every other week. So 1 week on, 1 week off, and that was continuity for the residents, for the patients. You know, so Monday's doctor says you're getting a C-section Thursday. Tuesday's doctor says C-section, we're going to induce her. You know, Wednesday's doctor says deliver her, send her home. You know, so continuity, and I think I did the best I could for all those years. I eventually switched that around. I was working clinic half the time. The 1 week, and then working labor and delivery on Wednesdays, and started seeing. Hi, love. Yeah, am I boring you?
She loves it.
She loves it. You love to talk.
Yeah.
And I started seeing private patients and loving that and loving what I'm doing. So I forgot where I was going with all that. See, just I'm a work in progress.
Your practices right now.
Yeah.
that you're
Yep. So I teach the residents in the clinic, but you know, most of my private patients don't want to see the residents, right? They don't want to be part of the training session. I have a couple patients, but I am committed to that training because these are Medicaid ladies, right? They are on Medicaid, and there is not a doctor in the city who will treat them. No one will hear them. No one will treat them. And I am committed to this, that they will have access. Yes, love.
You know what, all I wanna say is the other thing about that I didn't realize until just now is that, and I respect and I love the minute you told that story about being committed to those people. I'm like, yes, she's my people. You know what I mean? Even though I begged you to go to private practice. You were accessible for us. But the other thing is, if that's the time when you're training the residents, that's your opportunity to make the difference for the doctors in the future to understand this stuff for us. So that's a
No one else is tough teaching.
that's a big
No
twofold
one is.
win with that.
Yeah, so I'll tell you about that. So I, my dear friend, we went to med school together. She did family practice and moved to Colorado and taught herself to be an expert in osteoporosis, and eventually morphed into hormone replacement and started doing what I do, which is WorldLink Medical. And hold on, I got my mom is not doing that great today. So she's fine. That wasn't her. So she. I'm trying to think what I was going to say here. I'm sorry, guys. I am a little
that's
distracted
okay.
with my mom
That's
today.
okay.
So so my mom moved in with me in November, and she had urinary sepsis, urosepsis twice, and so she never really bounced back mental wise. So this is difficult. Now she's in some CHF this past week, so we're just kind of dealing with her. It's a challenge, yeah. So anyway, so my dear friend turned me on to WorldLink Medical, and she does pellet therapy and just absolutely loves it. I tried the pellet, testosterone pellet. So it's like a grain of rice that goes under the skin. I don't know, these things cost like $600. You have a blood level that goes up over that first month and then slowly tapers down over the next couple of months. It just wasn't for me. Like I did not like the downward slope. You know, then I had to use my cream. I was using my cream and had to pay for the pellet. This is ridiculous. Okay, this is not for me. But there are people who absolutely love that, but it is very pricey. You can get some pellet therapy somewhere in the city. There's a couple places that do it, but they kind of piss me off because they'll give you estrogen and not progesterone, and then they're bleeding, and then they're like, oh, you're gonna have to go to your gynecologist. Okay, so that kind of pisses me off. So anyway, so she came and gave a lecture to the residents, which was just outstanding. I mean, just outstanding. Her, for men, they have like 10 different erectile dysfunction drugs, and nothing for women, like literally almost nothing, and nobody's supporting the testosterone. And I said to her, you know what though? Those erectile dysfunction drugs, they don't do anything for their long-term health, right? So if you take the testosterone, part of it turns into estradiol. So the estradiol is what protects our heart. It fixes your lipid profile. Way better than your statin does, and without the added risk of the diabetes. So this actually does prevent the first heart attack. I'm reading a book that was recommended to me, Estrogen Matters, and you gave me that copy, right?
Yeah.
So I can't remember, was that the one I'm supposed to give back to you, or am I giving you this one back?
You can keep both of them, I can get another.
Okay.
Well,
Thank you for that.
hands.
Thank you for that. It's a book I've been wanting to read, and just actually the fear of breast cancer is, it's terrifying, right? And more than 90% of the breast cancer that's diagnosed today is 100% cure. 100% cure. I mean, very high cure rate. We catch it so early, very high cure rate. But the leading cause of death is still heart attack. Heart attack. 10 times the number of women die of heart attacks than even get diagnosed with breast cancer, let alone die. It's like 100-fold die of heart disease. So this is what needs to be the focus. This has to happen. We have to prevent that first heart attack. We have to do that, and the way we do that is by fixing the vessels, right? So it's high cholesterol leads to plaque buildup. That's why those women in that first study, that 63-year-old and on women died, was they were given that synthetic estrogen, and it caused immediate plaque rupture, which led to a little clot that goes right to the vessel, and they died. If they survived that first year, the women that survived, they actually did even show, even with the synthetic progestin and synthetic estrogen, that the heart rate disease died. The estrogen alone arm, they had an estrogen alone arm, still showed a decreased risk of breast cancer, heart attack, stroke, estrogen alone. So that has been taught, that if you have a clotting disorder, you can't go on estrogen, which is just bullshit. It's just not true. It's just not true. However, I do protect myself. So if somebody has a history of a blood clot or a strong family history, I don't want to get sued by their doctor for putting them on estrogen if they get another clot. They're still at risk for another clot, right? Whether I give them estrogen or not. So they're at risk. So those people, I make them do a whole year of topical, either the patch or the cream, just to prove that my estrogen isn't going to cause it before I transition them to oral. So that's worked out, and they're begging me, please give me the oral. Please, when can I start that? So anyway, so the oral is what goes through the system and goes to the liver. Liver, that it's called first pass. So then the liver, detoxifies whatever, any of our drugs, any of the food we have, detoxifies and puts it back out into the system. So that first pass is what actually we need for the cholesterol profile. That's what we need to improve the cholesterol profile. If you just have a patch, while it may minimally help your lipid profile, it's minimal. You have to take the oral estrogen. The other place to get it is with the testosterone, because some of it is converted into estradiol. And that's how, for men, being on testosterone actually helps them also prevent that first heart attack, because it improves their lipid profile. So, all right. I don't know where I'm headed next. Somebody tell me what they want to hear.
How about mentioning DHEA?
Okay. So DHEA is an androgen hormone. It's a kind of a pre-hormone, so it's in this pathway here, somewhere in here. And some of it is converted to estrogen, some of it is converted to testosterone, and It has specific indication for hypoactive sexual desire disorder, osteoporosis, and arthritis. So if anybody has the joint pain from the menopause, I definitely am recommending the DHEA. I feel like we get a much better response as far as the joint pain. Yes, you will get benefit from estrogen, from estradiol and progesterone, but all of these things work in harmony. Like if I had one patient who was like, well, I just want to try the one and see how I do. I'm like, okay, it's going to take us 2 years to get you optimal. we're going to start with one drug and see, check every side effect, and then we're going to add another. This is going to take us forever. This is not going to work out. So these things are going to work in harmony. It all works together. So not just one medication that will definitely put you into an imbalance. We need a balance. We need a balance. I have one lady, I'll tell you a couple stories of success stories. One lady, huh? Success stories. So this lady came to me. She was very excited to start hormone replacement. She had a fracture, one of her leg bones that was non-healing fracture, and had been like, over a year, like 18 months of non-healing fracture. And I said, okay, well, and she had osteopenia. Let's see what happens. Let's start the testosterone. We'll get you optimal. And then it was another little over a year that she was optimal on the testosterone. She had another scan, and it's the first time they saw bone growth. Another 6 months, it was looking so good, she was back to playing tennis. After it was well over 2 years, I think, that this thing was non-healing. So, miraculous. So what does it do in the bones? So in the bones, those other drugs, they add calcium, but not the way that our body normally adds calcium. So it can add density to the bones, but it doesn't necessarily prevent the fractures the way hormone replacement does that, or our own hormones do that. So it decreases the breakdown of bone and increases the matrix making of bone. So there's osteoclasts and osteoblasts. The ones that make it, the ones that break it down, and that balance shifts when we go through menopause. So we need to shift it back. DHEA, testosterone are best, estradiol, top of the line, also, for the osteoporosis.
And you had mentioned too that men can take the DHEA for joint pain as well.
Yes, so getting a man to get that testosterone checked and do all that. I mean, it's a pain in the neck. You got it those would be the men who really have that testosterone level less than 300 on 2 separate 8 a.m. blood draws. These are the guys who literally cannot get it up, have no drive whatsoever. They're losing their hair, on their arms. They're very low energy. So, but there are men out there who are just like, not as good as it used to be, right? This is something that they could take as DHEA. So I'm recommending a sustained release formulation because otherwise you have to take it 3 times a day because of the way it's absorbed. So for women, I start at 10 milligrams. Men, the starting dose is 50 milligrams. I usually recommend Nutriscriptives brand. So this is, I recommend MedQuest and Nutriscriptives. They're, there's the over-the-counter, the supplements, and the compounding pharmacy, and they're the sister pharmacies. Nicest people I've ever dealt with in my life. I mean, they're lovely.
Great.
They're just lovely.
Yeah.
And they are using for their supplements, their vitamin D, their vitamin B12, their DHEA, they're using pharmaceutical grade, and it's not coming from the third world. So it is actually pharmaceutical grade. It's not dirt cheap, but it is top quality. You're gonna get your blood levels with these. Nutriscriptives.
I'll send you a link.
Nutriscriptives and MedQuest.
Okay.
So MedQuest is for the testosterone, is where I usually order the testosterone from. So that's the DHEA that can help erectile dysfunction, somewhat androgen for men. So, and for women, the arthritis, the sex drive, the osteoporosis is very important. I usually check vitamin D levels and B12 levels just to see where we're at and recommend supplementation. That vitamin D, so we live in, where we live, right? So we all need vitamin D, especially in the winter. I'm usually recommending 4,000 or 5,000 of vitamin D. That 50,000 one, that prescription one, scam. So So that 50,000 once a week. So our body is not meant to do once a week to make vitamin D. It's meant to have a daily dose, right? We're supposed to have a daily dose of sunshine to make that. Of course, we all use sunscreen, so none of us are getting that daily dose. So that 50,000 though is a money grab. Let's see.
Can you mention too a little bit more about like the benefits of progesterone for the brain and the calming effect? I by the way,
This is a good one.
I listened to a podcast, and I'm gonna send you, I don't know if you listen to podcasts, but it was amazing, and they are using it to treat people with head injuries.
Progesterone.
Because of the benefit, like, it was amazing.
Women
Like,
only?
no, like, just
So they shouldn't use it for men. Progesterone in
There-
men is
I think
inflammatory.
they were talking more about, but they did say someone with like neuropathy on the feet, a cream on the feet for a man helped it. It was interesting.
I
But
haven't heard that one,
Never,
but because it can be progesterone can be inflammatory in men, so progesterone. So the progesterone, usually a capsule taken at nighttime, you need that first pass effect in the liver. So when it hits the liver, and then the main side effects of the progesterone, bioidentical progesterone, is improved sleep quality, decreased anxiety. Let me say that again. Improved sleep quality, decreased anxiety.
Yes, please.
yes.
It's gonna be a balancing, yes, love.
Can younger women take progesterone? Like, one of my daughters is very prone to anxiety, but she's not menopausal or anything.
Yeah, you know,
near
I'm
it.
gonna I'll be honest,
I know it's not your
I've been seeing
specialty.
some younger women with various problems, and there is, the lowest dose of progesterone available commercially is 100 milligrams. And I think that it might be too much for younger women, especially if they're slim. Somehow it just, I don't know, I haven't had that great success. Yes, you can. So yes, you can. So let's say that you have PCOS. You want to give them progesterone. You want to, simulate normal menstrual cycle. If you have cystic acne, I've had incredible results on a couple of ladies with terrible cystic acne. Perimenstrual migraine, I've had excellent results treating that. PMS, so this is the one that really is very helpful, but to find the exact dose is hard because it screws up their cycle, right? They're pumping out hormones, so me trying to give that progesterone, it can screw up their cycle. So, I'm learning. I'm a work in progress. I don't know. I can't believe everything I read about how great it's going to be because people are coming back like, well, my periods are so screwed up. I can't stand this. So then it's like, all right, what am I trying to fix here? So I'm not sure. Yes, I'm willing to try.
It's
And
it's still all the science is so new because they didn't really even delve into this stuff for so many years. That's what it feels like, right?
no, it's not new. These studies are old. The estrogen studies are outstanding and they're old. They go back-
Because of this big
suppressed.
one.
It got suppressed, right?
Okay.
It
It's
got,
there,
it got
but
It got poo-pooed, it got suppressed, and then there are, international studies that are literally just outstanding, outstanding. I'll tell you a couple other, hold on one second, sorry, there is a 2024 study came out, Medicare study, so over 65, and 19 million women, and it looked at ever users of hormone replacement versus never users of hormone replacement. The ever users in that same time frame, so these are women over age 65, the ever users had half the death rate in the same time frame, half the death rate. They looked at multiple disease states, heart attack, stroke, dementia, breast cancer, lung cancer, ovarian cancer, colon cancer, macular degeneration, and most of the disease states, especially in the bioidentical hormone, oral, were half of the rate. Not all. The breast cancer ended up being a wash, so I gotta look at this again in more detail. So the risk of 1, which is basically your risk because you're a woman, right? So it still ended up being a risk of 1. When I looked at their dosing, the way they did the bioidentical, you got a standard dose. So the high dose of progesterone was 200, which probably was suboptimal. So, so you just, there's a lot to learn, a lot to see. So let's see. Where else am I headed?
Is
Somebody
there
asked good
more-
questions.
Is there more research happening? I mean, because that was, 'cause I read a menopause book, woman from Houston, Mary Claire.
Yeah, very clear, yeah.
Yes, with the, yes, that one, with the,
Yeah.
dietary kind of stuff, but also that is there, and that there really wasn't a whole lot, or isn't currently maybe even about women in menopause. Is that something the medical community is starting more of, or is it still suboptimal?
Yeah, no, they're still doing the Nurses Health Study 2, which I'm a part of, which I joined in '85. They send out a yearly survey and ask you about, what you're eating, what medicines you're taking, have you had a stroke, just so
Right.
it's a longitudinal study. So that, of course, is ongoing. There's many studies still going on. They're always looking. The problem is that a lot of times they're looking at a new drug, right? That's a lot of the study is let's test this new drug. So I had a drug rep come to the office last week, and nurse practitioners were like, "Oh, you gotta talk to that." She is our expert. I was like, "Okay, let's go." Let's see what you. I said, "What do you got? What's your drug?" He's like, "Oh, so this is fantastic. It's just beautiful. We've got 2 different doses. It's an estradiol plus bioidentical progesterone. It's a combined pill. The progesterone dose is 100, and then you could either, have a 0.5 milligram of estradiol or 1 milligram of estradiol." I just looked at the guy. I said, "That's not enough progesterone." He said, "Well, what?" I said, "Yeah, that's not enough progesterone. I mean, minimum of 200, and you need to check a blood level." He was like, "I think you're probably gonna, let me get your name, doctor. You're probably gonna want to talk to our expert." So I'll just have him contact you. I said, "Okay, good. Yeah, we don't need those samples, thanks." I mean, I really hope to God nobody is prescribing it. You're gonna have a lot of bleeding. You're gonna have suboptimal. I mean, it's a whole milligram of estradiol and 100 of progesterone. People are gonna be crying.
So why would they do that? Because it takes
Oh,
away
because
your...
they finally have recognized that, hey, ladies want hormones, and this is let's get on board with this. Let's just put these 2 together. We'll say it's a new drug. We'll give it a new name. We're gonna give them everything, and they're gonna make some big money on this. And it's like, I shut him down in like 2 seconds flat.
And the worst thing is that a lot of doctors don't do what
Oh, I
they
can
do.
imagine that this is
Probably
going
jump on
to be
it.
prescribed, and people will feel somewhat better. Like if you take away some of the hot flashes, if that's your number 1 complaint. Yes, I mean that probably will work fine for that, but I'm not sure that that's going to do anything for your long-term health. With no blood check, some people that might be enough. Some people it might be
What
enough.
you do is hard.
It's not easy. I look at
A lot of
you.
Here.
I look at your blood count, your blood levels, your symptoms, and make adjustments. I want to talk a little bit about the thyroid. Every one of you has been told that your thyroid is normal for years, no matter what your symptoms are. My hair is dry, my skin's dry, I can't lose weight, I feel bloated, I know something's wrong with my thyroid. Check my thyroid. Yeah, you're fine. Oh. So over and over, and so they're only checking, number 1, they're only checking the TSH. If the TSH is normal, that's the thyroid stimulating hormone, you're fine. So there are so many people who are hypofunctioning, right, of the thyroid. So even though that TSH is normal, if I see a TSH at 2, so if you have a whole range, right, from 1 point something all the way up to 6, and you're here in this low level of these hormones. I mean, are you normal? Are you actually normal when you're, like this? I mean, no. So people have all the symptoms of hypothyroidism, and so I do a little trick in the wording and call it subclinical hypothyroidism, which does have a very specific diagnosis. And I haven't had a single insurance company call me on that one. So Yeah, so that's what I use most of the time. So I'm learning, like in the first, year and a half I was doing this, I was starting people on everything but thyroid replacement. And then we'd get through all the way up to optimal. So first you're gonna feel great, and then you'd be like, yeah, I don't know, I'm not feeling as good as I was. Okay, well, let's check your levels. And then finally we get to everything is optimal, and I'm still having people coming back like, I still have this fatigue. I'm just so fatigued. Yes, I'm sleeping great. The progesterone, I'm sleeping great. Everything's fine. All my labs are normal. I still have this fatigue. And then I'm like, well, let's add the thyroid. We'll add Armour thyroid. So Armour thyroid is the old-fashioned thyroid. This is the one. This comes from desiccated porcine thyroid. All the pork, whatever, is taken out of it. I don't know. I'm not a chemist, but all of that is taken out. But what it contains is T1, T2, T3, and T4. So T3 is what's active at the cell level. So I'm going to say in the 70s, the greatest marketing ploy of all time, Synthroid. You don't need the T3. All you need is T4, levothyroxine. That's all you need. You just need Synthroid. And I honest to God, this had to be the greatest marketing ploy of all time. And that's what everybody gets. And then people are still like, yeah, I mean, I work with Dr. Lippies, and he's just like, your thyroid is normal. Well, their thyroid is in the toilet, and they're still looking terrible, and yet blood level's normal. So he's an endocrinologist. He is to the letter. If you're within the normal range, you are normal. Thyroid's fine. Just go on a diet. So, okay. So I usually use Armour thyroid, even though your blood levels are normal. They're probably, if a TSH is above 2, or you're severely symptomatic, right? This fatigue, this overwhelming fatigue, it is overwhelming. The first time you come and I'm giving you 6 different meds. 6 different meds is a lot. Like you got to get a pill case, right? So I mean, this is a lot for some people. But I think putting it all together in harmony is going to be better. It is better. When I add that final piece of the thyroid, I think everything clicks into place. So I think it is imperative that is added. And so then the TSH is low. It gets suppressed. The brain gets suppressed. It doesn't need to stimulate the thyroid gland anymore because we're replacing everything. And then the primary doctor's like, what is that gynecologist doing with your thyroid? This is suppressed. Well, yes, it is suppressed, but they're not hyperthyroid. They're not hyperthyroid. They're just on enough medicine. So I have treated a couple ladies with a history of thyroid cancer. Thyroid's been removed. They don't have the capacity to make that T3, and they still are feeling not as great. So they've done better. With the Armour. So trying to do all of that.
I will speak on that.
Okay,
I
let's
take
hear it.
a low dose, and I would have afternoon fatigue. Like if I was driving home, I could fall asleep. For that period, I would be really tired.
Me too.
And right?
I fell asleep driving once.
You did? I mean, I would get oh my God, I'm so tired. Like at 4 o'clock, if I sit down, forget it. If I'm still moving, I'm fine. But also freezing to the point where it's painful. And I would say to my doctor every year, could there be a reason? Could my thyroid make me? I'm freezing all the time, painfully freezing. No, it's all fine.
Look at what she's wearing.
I have not been wearing sweaters. I'm the first time temperate in years, and I have not been freezing since I've been taking it.
Were you on Synthroid?
No, I had nothing. No,
Because
but
I've been on Synthroid for years,
no.
but I'm still.
no, and now I'm
Normal,
I
you're
take
still
a
normal.
little bit.
Pardon?
You're still normal.
I am you see me this sweating, and then you see
I
me going
am
this because I'm
But wearing
freezing.
sleeveless
so
for
funny.
months now, and I'm I am not
That's not.
cold anymore.
That's awesome.
But are you
Thank
overly hot?
No, I'm comfortable.
You're comfortable.
Temperate. I'm
Ah.
perfectly temperate.
Okay.
Yes.
And you think it's because of the.
Oh,
Armour
100%.
thyroid?
100%.
Yeah, definite change.
Yeah.
Definite.
Definite. I honestly, I'm telling you, I definitely feel very optimal,
I wish I knew this stuff for my mom.
I know, right? And
my
my
mom
mom,
took Synthroid forever,
Yeah.
froze forever.
yeah, my mom was in the first study, the women's
That's
health.
right.
She got the placebo. But I feel that my mom is up there saying, "Come on, push this, teach women," because I know mom would have been very
Agreed.
excited about this. And my mom had osteoporosis, she had dementia, she had heart disease, she had urinary issues, she had all the things. And it could have helped her, and I know she knows that, you know?
So when I went to the first session of the hormone class, I, was in this classroom, in a hotel thing, and so I had the sweater, I had the shirt, I had the sweater. I finally got my hoodie out. And he says, he looked right at me. He's like, so, I mean, one wonders what your thyroid's doing. Look at, and he pointed to the head pharmacist who was in, just literally, just like that. And he was like, I'm thinking something's going on. So, I'm like, oh my gosh, he is right. He is right.
But I have never,
So cool.
never been able to do this. It's so comfortable now.
That's so awesome.
Yeah.
That's so awesome.
Yeah.
A couple of other health benefits I just want to talk about with the hormone replacement. I mean, what about dementia? So there's a study out there that showed that if you took estrogen replacement therapy, it worsened dementia. So that's synthetic. That was the synthetic. The actual estradiol decreases the rate of the tangles in the brain. So it decreases the rate of Alzheimer's. It can reverse and treat macular degeneration.
Wow.
So I have, one sibling who's all on board and taking everything, and she's just optimal and looking like $1 million. I also have her on semaglutide, which I'm a firm believer in. Very helpful to have this medication to put your body on a better path, decrease insulin resistance, does everything, accessorizes with the hormone replacement to improve insulin resistance, which is the leading cause of everything. It is thought that the etiology here of polycystic ovarian syndrome is actually insulin resistance. So what happens? Why do we suddenly become diabetic? Well, when we're younger, and then all of a sudden we go through menopause, now we get this abdominal fat, this visceral fat, which is insulin resistant, and then the lipid profile starts tanking. Then they want to start a statin on you, so then they start the statin. Now you've already got some insulin resistance. Now you're diabetic, and you got the statin, and they're upping the statin, and now they're starting you on metformin, which I'm not against metformin. It's awesome, but it starts us on this path, and it's menopause that starts us on the path. But if we go the pharmaceutical route, we're going to end up, it doesn't really improve things anyway that much. So really got to work on the hormones doing that. Macular degeneration. So I have another sister, she's a psychiatrist, and I cannot get her on board. I'll be honest, I cannot get my sister on board. So it's okay. Her doctor wants to start her on a statin. I was like, what? Don't you dare! Don't you dare! That's gonna give you diabetes. Her husband has diabetes. That's gonna give you diabetes. She was like, I've never heard of that before. I could teach 1 million people. Everybody's like, well, she's the greatest. My sister's like, you're a baby doctor. What do you mean? No, I'm not listening to you. So she calls me back. She's like, well, we did read that. We did read that. That's a resistance thing. But so she doesn't want my mother to do anything. So my mother was on Prempro years back, never wanted to come off. Can't remember what, I think it was after the WHI study, and then she eventually got off stuff. She was in a study too. She was not taking a placebo. She was a UV study. And so I really, she's got the dementia, she's got the macular degeneration, and I've got my sister like standing her ground that I will not be doing this, so my mother's afraid now. So I know, there's nothing I can do. I can only do what I can do. We're all only human. Yes, love.
Switching a little bit here.
Yeah, anything. Okay, I'm ready for anybody to ask any question, anything. I've rambled enough.
I'm not even sure where I'm going with this, but
Well, I don't know where I'm going either. So
we're in the same boat. So friends of mine who've had breast cancer
good question.
are taking pills to not have any estrogen. Is that, they were never on estrogen, no hormone replacement. They got breast cancer, and now they're told, gotta eliminate all estrogen. Does that sound reasonable?
Well, that sounds common.
Common.
Yeah, so that is the prevailing wind right now. So if estrogen caused breast cancer, not one of us wouldn't have it, right? We would all have it. We would all have breast cancer. So estrogen does not cause breast cancer, number one. It is actually the synthetic progestin that slightly increased the risk of breast cancer in that study. So it does not cause estrogen, even the synthetic estrogen arm had a decreased rate. When they came out with that tamoxifen, raloxifene, that was actually originally for women that they said couldn't take estrogen for whatever reason, blood clots, whatever the reason was, to treat osteoporosis. And it was like an anti-estrogen. It did okay. Like I said, a lot of those drugs have been developed because of the fear of estrogen. So where are we as far as estrogen? Can we give women estrogen who've had breast cancer? So first of all, that those tamoxifen, raloxifene, those drugs actually decrease the risk by like 4% or something. It's like it's barely anything.
Decreases the risk of
Recurrent breast cancer. Okay, it barely does anything, because if you have breast cancer, you're at risk of getting it again, right, on the other side. Just taking out the breast doesn't, it's your whole environmental, everything, whatever, genetics has you at an increased risk. So actually, estradiol, bioidentical hormones actually do decrease the risk, and I'm blanking on the percent, but it's like 20% risk reduction, something like that.
No doctor's going to want to do that because of exactly what you
Well,
said earlier.
I am treating women who've had breast cancer now. So 5 years, no evidence of disease. I have treated a couple patients. If they're strongly desiring, and yeah, so they're ending up with a lot of problems because of the anti-estrogen, and high cholesterol and central obesity and insulin resistance and osteoporosis, and I think they have a high rate of macular degeneration, and so it's.
So what if you have a close friend that is in this
You can say
situation?
nothing,
Nothing.
zero. Mm-mm.
Okay.
I cannot fight oncology. I can't.
Right.
Yeah.
I cannot. So what I do, so one of the things I do to protect myself, and this is related to the thyroid too. If my guru says if somebody else looks at their blood and they say, but my doctor said, then just tell them go to your doctor. I'm done. I can't treat you anymore. So I haven't done that yet, but I get where he's coming from, because I have this one patient who, she's on very good doses of testosterone, her level's fantastic, and her she's not bleeding anymore, and her CBC, her hemoglobin went up to like 16. This is not like dangerous. This is not polycythemia vera. It is an elevated red blood count, but it's not the dangerous kind. It's not a pathologic. And this one's telling her she's got to come off that testosterone. This doctor needs to be following this and doing something about it, and you need to see somebody else. And she's like, yeah, no, I'm never going back to where I was. Never. So as far as the breast cancer, I tell all women that you're at risk for breast cancer. You're a woman, so if you get breast cancer and we're on this, they're going to blame the hormones for the breast cancer for sure, and someone's probably going to make you come off of it. So I do have a lady who right now is going to Roswell. She had a Insight 2, and I said, well, we talked about this before. She said, oh, I know, but I'm never coming off the progesterone. I said, okay. Okay. All right, good.
I think it's worth the risk.
I mean, you
for
have
myself.
to weigh your risks,
Yeah.
right? What
In my
do we
mind.
want to die from?
Yeah.
Do we want to die from, a small chance of dying from breast cancer or heart disease, which is much higher chance?
Which the risk for the breast disease you have either way.
Either way.
Yeah.
Yeah.
So the chance of
With
dying
it
from
comes
heart
risk.
disease
Yes, right.
is way higher.
Mm.
So, and I think we all have, I don't know, that senile dementia kind of thing, that one scares me. We're all just, as you get older, you're just like word finding problem, right? Me,
That
just
happens
like
to
losing track of where I
very
am here.
Mhm.
And even with my hormones,
neurotransmitters.
it's just some of that comes with aging. Okay, ready for any other questions? What else we got?
It is the testosterone cause years ago, is testosterone more regulated? Cause like I was in my 40s and was prescribed estrogen, progesterone, testosterone.
Was it a cream or what was it?
It was compounded at a pharmacy. I think it was a pill. But it was a different state. I don't know if it's
Yeah,
different state
so
to state.
testosterone is not well, like to get your testosterone level up from oral, they are working now on a pill that will pass through the stomach acid and be able to
Otherwise,
absorb.
would it have been a cream? Cause I don't even.
No, the testosterone, I mean, I have a lady who came in with a pill like that, so I don't know, her testosterone level was like nothing, so.
They prescribed me Ester test for years.
Oh yeah, that was a
Estrogen,
cream, right?
testosterone. No, it was the pill that I took for years, did nothing. It was estrogen
I mean,
and
it was,
testosterone.
I
one
believe
pill.
it was like a micro amount of
I'm sure.
testosterone, and plus it was coming orally, so
Yeah.
I don't know.
It was a million years ago, kind of.
But there was a cream that was Ester Test cream too that I knew people who were getting that. So I think taking it orally, you're not going to get great absorption. Like I said, I am the pellet, the cream. So the way the cream works is it's placed on the vulva. Mucosal absorption is much better than intact skin. So if you under the arm or behind the knee, I have a few women who cannot place a cream here, like no how, no way. So, like, okay. All right, that's fine. No, I seriously, I have a lady who was sexually abused, and she came to me having not been able to have intercourse with her husband for 7 years. And he's a really good guy and really, really wanted something. So I said, okay, so we would do estrogen, progesterone. She was on multiple psych meds, depression, anxiety, bipolar, I think too. And so we'll do estrogen, progesterone, and testosterone, DHEA. And she came back for the first 6-week checkup, and I did an exam again. I mean, she completely constricted vaginal opening, completely constricted. So as I came back into the room, she was on the phone like, she said there's some slight moisture there. So the next visit, I mean, I was like, okay, I mean, this is looking better. This looks a lot better. Like, it's not completely, and I had a medical student, a resident with me, and he comes out of the room. This was in the private office, so they rotated like once a month. They came to this private office. He comes out, he's like, this lady's very excited. I said, okay, what's going on? He's like, she and her husband had sex after 7 years and it didn't hurt. I was like, oh my God. So I walked in there, I said, how's it going? She was like, yeah, we had sex. I said, oh, that's so great. You guys must be so proud of yourself. She was like, yeah, we are. I said, okay, that's great. So the next time I saw her, we upped the dose. The next time I saw her, blood level was fantastic. And she had had an orgasm, which she hadn't had an orgasm since she was in her 20s. She was in her mid-50s. She had had early menopause at like 44. So she had had an orgasm, and it was like, I mean, I'm like, you guys, this is amazing, right? This is amazing. So she said, yeah, it is. So they were going along. Everything was fine. She was having orgasms. They were having regular sex. Everything was going great. And she called me one day. She was like, I don't know what's going on. I mean, something's wrong. I'm not able to orgasm. I said, okay, let's check a blood level. So we checked the blood level, and it was like a quarter what it had been. Like, just discussing it, where are we getting it from, what's going on, and she was getting it from Pine Pharmacy here in, on Main Street. I said, well, that is so weird. I think we should go to MedQuest. Let's switch to MedQuest, and 6 weeks later, she called me. Yeah, everything's fine. Everything's good. We checked the blood level. We're all good. Everything's good. And it kind of happened. So then she called me. She called me and she was like, "Listen, so I need to talk to you about something." Okay, what's going on? Well, I'm waking my husband up every single morning to have sex now, and he actually said the other day, like, he's tired. I don't know, I guess I'm tired too. I mean, we are having sex every single solitary day. I said, okay, all right, listen, I think maybe, let's just decrease the level just a couple times a week, put it in an alternate place. I think this will drop your level, and we'll be back to exactly where we want to be. Not too much, not too little. I mean, this was a guy who was like, he wanted a lot of sex. And he had reached his limit. So the dose, let's talk about the dose. So for a man, the starting dose is going to be 200 milligrams of testosterone. For a woman, we're starting at 5 milligrams. You're gonna place this externally on the vulva. It comes in like a little garbage can. You tap it on the counter, you take the lid off, there's a dial on the bottom. Single click is the first dose. It's 5 milligrams. It comes up like a little pearl. You take the pearl on your finger and place it externally, internally, externally around. That's it, it absorbs. 4 hours before you have intercourse with that, or place it after intercourse. But I wanna say again, because it could transfer to the man, right? And the last thing he needs probably is more testosterone. But on the other hand, your little 5 milligrams is going to do nothing if his starting dose would have been 200. So I don't worry too much about that it could be transferred to the man. The highest dose I have a woman on is 60 milligrams. So not 200, nowhere near that. Again, this is not sex change. It's not, no one's transitioning here. You might have some side effects of increased hair growth. You know, deal with it. I have another medication for that too to help with that. So if that's the main problem, we can deal with it. Okay, what other questions do we have?
So if a doctor is saying that your cholesterol is reaching a level that's higher, and they're concerned, and they might want to start you on a medication, your first response would be?
Oh, hell no to a statin. Oh, okay, but us. Hormone replacement would be my answer to that. Your cholesterol is going up because you guys can leave, anybody can leave anytime. I'm not offended. Yeah, we're here a long time. I don't even know
My
what
cholesterol has gone down since I've been on. I can tell you.
Why doesn't your regular doctor know that? Like when you're like,
So-
this is dangerously high or?
I just went to, I had blood work and, you know, it was showing that those levels are going up again. And at one point, the doctor, this is a different one, had put me on statins. And then I felt like, no, I don't want those. So I stopped myself. And when I looked at the blood work and I saw those red, you know, you're in the red zone, I'm like, shit, they're gonna put me on it again. So I went to the doctor. This was a young, I think a nurse practitioner, I don't know what she was. And I said, I don't want to put me on statins again because I really don't want them. She goes, no. She goes, no. She goes, you try with your diet, you're trying these other things. I'm not one for putting people on statins. I'm like, hallelujah.
Hallelujah.
Because don't they also
They
change,
all
they've been changing the numbers?
Yeah, the numbers used to be like 300 and now they.
Oh, they're lowering the numbers.
Yeah, yeah.
No, they lowered them so
Right,
that they
okay.
would, so
Yeah.
that people would get the
Yeah.
drugs, so the money, you know, so.
Yeah.
So then you're like, who do you trust? What do you?
Exactly.
Okay.
Mhm.
This is why
I mean, the evidence,
Are you
the
tired?
preventing that first heart attack in men is not that great either. But there's zero evidence in women. Zero. No evidence for that. Okay. Any other questions?
Do you add any vitamins and supplements along with the regime of the hormones?
I mean, I do look at vitamin B12 and D because they are kind of like feel good. Like these can really give you a lot of fatigue, and replacing those to much higher than, you know, that low, slightly above normal can actually, you know, enhance how you feel. So, and there's, you know, tons of research on those. And as far as the other supplements, like I know there's so much stuff out there. Like I cannot even pretend to be a supplement expert, no, by no stretch. So,
But if anyone is looking, like for
Mhm.
supplements, Dr. Levy, who's my functional nutritionist, and you can watch on the Facebook Live, he was here with the nutritionist. They know about supplements, yeah, they're excellent, and they will sit down, look at what you take or recommend, and really good at making sure you get the best quality and stuff. He's excellent like that.
Yeah.
that's
he-
cool. That's cool.
He did start me on DHEA.
Yes,
What
good.
dose?
Over the, I started at 5 for 2 weeks and then he upped it to 10.
Mhm.
But it's over, I
Sustained
think it's,
release?
I don't know, it's Vital, I think it's Vital.
I gotta look and make sure it's.
No,
Yeah.
it's not the
Sustained
sustained, the
No.
only place that I've been able to find the sustained release
Mhm.
is MedQuest.
Okay.
Which is online, you can find, it's called MedQuest, but, they have it in 5, 10, 20, so,
Okay.
Yeah, so
yeah.
Okay.
the Nutriscriptives brand was on Amazon for a while, and then it's not on it now. And it was not any cheaper than going to the company. More convenient because they would send it in a day, you know, if you had Prime. But they have a whole list of supplements, and I'm sure there's just innumerable data out there that could be helpful or harmful. So a lot of the stuff that women were told to do when they couldn't do hormones, the black cohosh and different stuff, was actually harmful. Some of that was harmful. So I'm not recommending a ton of different, but I support you if you're doing it. I support you for that.
And I am on the NP thyroid. I'm on
Okay.
NP, yeah.
Great.
Yeah, and he changed it from 90 milligrams to 120
Excellent.
because I was tanking, you know,
Mhm.
so he'll check my levels again, I think, next month.
So I think 120 twice a day is kind of a maximum dose recommended, but if your levels aren't good or you're not feeling good, they could go higher than that. Every time I order it twice a day, I get a little warning like, oh, you're only supposed to do this once a day. But people have tank in the afternoon,
Oh,
right?
yes, oh, yes.
So
Mhm.
taking a
Yeah.
second dose in the afternoon, dividing up that dose is beneficial. Although it is a very long acting,
Right.
somehow adding that afternoon dose is very helpful.
Yeah.
The thyroid,
yeah.
the thyroid.
Now, what is the, if someone was on Synthroid for a long time and then they transfer over to
I have a
the-
conversion factor, not off the top of my head. I
Okay.
gotta
Yeah,
do the math.
no.
I could do the math, but I do the math.
Okay.
I have that little math in there somewhere. It's written down.
Yeah, no.
Okay. Any other questions? Anybody I can talk to you individually. Anybody wanna come up? I'll just talk to you, sure.
Are you taking new patients?
Oh, sure. So,
Yes.
that's the thing. I right now I'm seeing every other week. I have a private office session. I'm only seeing 4 new patients at a time at that session because, like I said, these are at least an hour, and then I've got my follow-up. So I'll see you the first time, and then we do labs. Usually I do labs the very first time just to see our baseline, see you in 2 weeks, and then prescribe meds. From there, 6-week lab, 8-week follow-up, 6-week lab, 8-week follow-up. Once you're optimized, spread that out to every 3 months, every 6 months. Every 6 months will be the goal.
So there's a little bit of a wait, but they're getting much better if they have cancellations at getting people in sooner, because they did it for me as well as my daughter who's coming this coming week.
Oh, good.
It's well worth the wait.
Oh, good.
My
Okay.
sister made an appointment.
Oh,
The
she
one that
did?
came last time.
Okay.
She was all excited, and she called, and they took a little while, but they apologized, and they were able to get her in September, and she's
Okay.
so excited. But
Okay.
they said, "Did you attend one of those talks?" And she's like, "Yeah," and they're like, "We gotta go and listen to what she's saying." Like all these women.
Yeah, one of my girls is supposed to be here today.
Oh, your staff, the
Yeah.
girls at the
They're
office are
great. They're
wonderful.
so nice.
They are awesome.
They're very excited about this, and
They're
they're,
super.
everybody's
And
learning.
Can I also mention, you do this on your own time. Like when she takes these appointments, she's not getting anything extra for this. She does this on her own time. Like this is
I do get paid.
right.
I,
But I'm just
I
saying,
get paid. I
it's
am
not
paid.
like you get extra for doing this.
Yeah.
Is what I'm saying, right?
Right.
Right. So
I think
she's
it's
like made
fair
this
to-
time.
I think it's fair to say that she's an advocate for
Yes.
health.
Yes.
Personally,
so.
very
Yes.
strongly.
And if anyone does want, we do have copies of these up at the desk.
Okay.
So we will.
So I will say this about the book. So you cannot buy this yourself now online. This is his new book, Neil Rosier. He's my guru. His book, How to Achieve Healthy Aging. You can buy this online. This is his older book, and this book is for everyone.
Yeah. It's really.
Physician, non-physician, layperson, but it's more for a layperson. It does mention all the studies, and they are all in the back of the book. If you are highly interested, you can find them. This book, I think, is a little more detailed, looking, describing what the study showed and each specific study, and but they're both excellent. So, right now I'm paying out of pocket for these. So if you want one, I'm paying $10 for them. I'm happy to take $10 for them. So. I'm
And
not
it's
getting-
up to date, like it's a newer.
Brand
It
new,
just came
brand
out.
new.
Yeah.
Oh.
You cannot buy this
Yeah.
anywhere but from me.
Okay.
So
I
if-
read it from my friends, and
Oh.
I said I have to go get my own. I
Oh,
wanted to
awesome.
mark it up, and I can't do that.
That's good. That's
But
good.
it is easy to understand. I mean, it gets into tests if you're really into all the detail.
Mm-hmm.
I just sort of like, okay, I get it, but I want to know the outcome. That's where I want to circle.
Yeah.
you
I want
know.
to say one other thing. Sorry, I forgot this. Let me go back up to my picture here. This thickened endometrium and why you need the progesterone. Over time, if you don't stabilize that lining layer with progesterone, you can overstimulate the lining layer. Leads precancer and endometrial cancer. So that is why that 100 milligrams is suboptimal. That new drug
And
that's
that's
coming
why
out.
we kept,
Yeah.
keep
So-
going and having biopsies, because they
Yeah.
wouldn't raise it to,
Yeah, I
they
just
would only
keep
give us
getting
100.
biopsies.
She gave me 100, and when I said, can I just try 200 and maybe that'll stop? Which it did immediately, but nope, that's too much. You can't take 200.
You
I'm
can't
on
take too much
300.
progesterone.
I'm
Yeah,
at
you
300
can't-
now.
I'm
I'm
on
at 300, and no, but it was
Yeah, you
like,
can't take too much progesterone, honestly.
yeah,
Oh,
You
You're
can.
on 300.
300, and
Okay.
the relaxation benefits and the
Yeah.
sleep, I mean, it's huge. It's huge, yeah.
Yes, I have a very sassy African American woman who very sassy, and but she is never coming off her progesterone. Let me tell you that she is never.
Because it helps with anxiety.
She sleeps. Your
Oh,
mood is
Anxiety,
good.
the mood, the
She.
GABA.
Mm-hmm,
Yeah,
I'm
makes
sleeping like
sense.
she's on 400 milligrams.
Yeah.
Sleeping like a dream. No, never coming off.
But they put you on like, I don't even know how much estrogen they put you on,
Yeah.
like probably
5, like
something
the
like,
5 milligrams.
I don't know, it was like
start.
a big, like.
5 milligrams?
It was like the biggest one, and then we were gonna dial it down.
Oh my
Lord.
And I
Were you
thought I was
crazy?
losing my mind.
I know, I
You-
felt terrible.
You know,
Yeah.
like I was losing my mind. I thought I was crazy.
And bleeding, so much
Oh.
bleeding.
Bleeding.
Yeah.
So, yeah.
Oh, bleeding too? Oh, thanks, Pat.
Oh, so.
Oh,
Appreciate
yes, so we've come a long way.
And with the hormone replacement, like I'm on a statin. So my dream would be to come off of
Sure,
that because my A1C does fluctuate. So now you've enlightened me
Mm-hmm.
there because,
Yeah.
Yeah.
And Dr. Levy does really want to meet Dr. Coggins to talk,
Yes.
like, because
Yes.
he, and he got to meet Debbie, and I love like making, those connections because I feel like,
You're making a difference.
But
Yeah.
but I think like he's so open to I mean
He
he's
is.
so knowledgeable
He
and
is.
so I mean he's the one that put me on BHRT to begin with.
Mhm.
But he's so like that the armor thyroid as opposed to the others, like he's very open and holistic.
Yeah.
Is that the primary?
You have to have a real primary, but because he doesn't take insurance.
Okay.
But he again,
Functional
you just
medicine,
pay for
New York
the
State.
Yeah.
for the visit and with supplements, he gives you his practitioner number so you get him at cost. Like he said he doesn't want to make anything
Yeah,
from those.
full smoked, yeah.
Yeah. So I mean that's a
Yeah.
benefit too.
And they
He's
saw
very knowledgeable and very just being open to it and wanting to know more and he's
Yeah.
great.
That's cool.
Yeah.
Well, he said he was gonna keep me on the statin only because of my family history.
Right.
My parents,
We-
my brother,
yeah.
but
I'll have.
I would be heart
Yeah.
issues, yeah. But
But I think
Yeah.
he would be. I mean, he's very reasonable. When we were having that discussion,
Yeah.
he would. He sees both sides, and
Yeah.
So I think
it's a good thing.
as you're on the hormone replacement, you get your cholesterol checked and then say, can we lower the statin?
yeah, because I would like to not take it.
And then the next time, can we lower the statin? So, oh, you're perfect now. Yes, I'm on hormones now. Can we lower the statin?
Yeah. Okay.
That's how you go about that.
Okay, okay.
And it just blows me away that there's zero evidence
Zero.
that it prevents.
The first
Right,
heart attack in
right,
women.
yeah. And
So there's
right,
a
he's
small
a-
amount of evidence for the second heart attack. If
Why
you have a
would-
heart attack, there is some small evidence that,
Okay.
like a 4% drop, decreased risk or something like that, very minuscule.
Yeah.
So.
Very eye-opening. Thank you so much.
Thanks for coming. I'm happy to talk to anybody.
She said she wants to talk first.
She wants to